going live. All right. Yeah, all right. Good afternoon, everybody. All right. Today we have a couple of special guests. We have 97 viewers right now.
Okay. I see Jasmine on the YouTube channel, so I think we're good. Today we have Chief Womack and Mr. Richard Schomp joining us as well. In the comments, can you all please let us know if you can hear us okay and see us okay and all that, and make sure this is working. Okay, maybe. Loud and clear. Excellent. Very good. Here we go. Bring back the beard. Amen. I cannot wait to have a beard back. It's terrible. I was just telling Jasmine not to click go live until I fix my hair. I've got some work to do here. We'll start with today's case counts, and I will pull them up here real quick. Okay, here we go. Sorry about that. All right, so today's case counts, we are almost 23,000 for the state of Florida. There have been 3,300 total hospitalizations and 633 total deaths in the state of Florida from COVID. You can see here this graphic down here shows possibly a decrease. I think it's too early to say that for sure. I think there's some artifact in there from testing. And based on what we're seeing locally, I wouldn't be surprised to see this tick up a little bit again here soon. It still does seem to me like it's a little confusing as to whether we are in the calm before the storm or the storm has gone from a category 5 to a category 1. I think it's a little too early to say that, and I honestly don't know the answer to that. Here is the other data that the state provides on these cases. By now, you all probably have this website and can look at it yourselves, but I thought it's just worthwhile to show for the general. All right, so it looks like I'm gonna have to take a consult. So let's go right here to Chief Womack and Richard talking about PPE use, standoff assessments, and all that kind of stuff while I take this consult.
Good afternoon, everybody. Ian, do you want to take off or lead off?
Did I lose you?
No, there you are.
Yeah. All right. Assuming everybody can hear me, how's everybody doing? Thanks for coming on for the call. I know from our field personnel, we get a lot of positive feedback from this. They certainly appreciate hearing directly from the doc. And we're going to take this as an opportunity to try to clarify some confusion that we've been receiving from our field level folks, our field supervisors regarding the PPE guidance. I know Schomp and I are on together to try to present to you what is a cohesive strategy, and hopefully that'll clear up some of the guidance that's coming from the medical director's office to the field level. So I'll just give you the first responder perspective, and then let Schomp weigh in on the Sunstar perspective, and then we can answer any specific questions that you guys might have. And then we'll try to also identify, I think, what's driving some of the confusion that we've been able to figure out in the last few days as we strategized how to clarify the information. So the most recent medical control directive was issued last Thursday, went in effect Friday morning. That's 2020-14, where it again reiterated what the PPE guidance is in there. And it also provided a placard that's supplied in each vehicle as a general reminder. If you'll remember before, when that placard was issued, even before we went to baseline PPE on everything, we were doing the standoff assessments. So just as a review, the direction is we do a standoff assessment for every patient we encounter contact. Now, there was a period of time that we were doing standoff assessments in our regular PPE of basically gloves and eye protection. We saw some uptick in community spread, and the doc felt it was appropriate and safe for our people to move to a higher level of baseline PPE. So that medical control directive was issued March 28th, I believe it was. That was 13.2. That had basically established a baseline PPE for every EMS patient contact. And that baseline PPE is some sort of respiratory protection, either an N95 or the 3M full face piece mask, eye protection if you're in the N95, and then the gloves. That's non-negotiable in the guidance. So every time we have a patient contact, at a minimum, it's baseline PPE. And we start with the 6-foot standoff assessment. And then that's where that placard comes into play. In your standoff assessment is when you ask the questions to determine the COVID risk associated with the patient that you're about to engage with. If the patient answers positively to any of those COVID risks, then the card goes to step 1. You don your full PPE, and then you wear that full PPE for the duration of the incident. Another way to think about it is if we were automatically donning the full PPE on every call, then there would be no need for a standoff assessment. The standoff assessment is designed to give you an opportunity to determine your level of risk and then don the appropriate PPE to meet that level of risk. And this is why that's important. One, it gives you an opportunity to make sure you understand the risk associated with the call that you're about to engage in, but it also gives us an opportunity to be purposeful about the use of our PPE. We do not have an endless supply on these gowns or any of these items for that matter. So we need to be intentional about their use. We certainly need to use them when they're indicated, but we also need to be careful not to use them when they are not indicated. So that's really the overall 30,000-foot view of what the guidance is. So if we were to simply summarize that in a handful of bullet points, it's on all EMS calls, one clinician in baseline PPE does a standoff assessment. If during that standoff assessment, that clinician determines that respiratory isolation precautions are warranted, then they would don their additional PPE and continue to engage with the call in accordance with all the published guidance. If during that standoff assessment, they determine that respiratory isolation precautions are not indicated, then there's no need to don the full PPE. They can continue in their baseline PPE. I believe perhaps where some of the confusion has been entered into the system is we have empowered our clinicians to use their assessment on scene to make that determination. And that meant that they could cancel, per se, a RIP warning. So dispatch puts a RIP note on a call. That's an early indication, an early warning for you. Absent any other information, you should appropriately respond as if that RIP note was 100%. But you get on scene and you realize that somebody else called 911 for the patient. The patient doesn't have any of the symptoms that were told to 911 because it was a third-party caller, it wasn't with the patient. There's nothing in your assessment, your standoff assessment with that patient that indicates a need for respiratory isolation precautions. Then you can proceed in your baseline PPE. You don't have to burn a set of PPE just because the dispatch note was there if what you find when you get on scene doesn't match what the dispatch note was telling you. I'll illustrate it this way. We get dispatch calls all the time that indicate one thing. We get there and we determine something else. We always let what we find on scene guide our actions and our decision making. What the clarification is when Dr. Jameson says that for a respiratory isolation precaution, full PPE is always indicated, that's because if you find any information in that scene or in your engagement with the patient that warrants respiratory isolation precautions, there is no option but full PPE. But as the clinician on scene, you're best positioned to gather that information up and implement the appropriate level of PPE based on that. So that means if fire's on scene first, and say we get dispatched to a call that has a RIP note, We get on scene, we start our standoff assessment and our baseline PPE, and our clinician makes a determination that this doesn't warrant respiratory isolation precautions, and none of the risk factors can be identified. We've told our personnel that they can proceed in baseline PPE, and they can advise the Sunstar crew, hey, we've gone through the screening process. There's no respiratory isolation precautions indicated. I'll let Richard talk to the guidance for his crew from there, but that's something that we've empowered our crews to do. We've also empowered our crews to take that information from the Sunstar crew. If a Sunstar crew gets on scene first and they do their standoff assessment and they determine that baseline PPE is appropriate and they don't need the full isolation kit, then they can advise that of our people, and our people are empowered to follow that advice and stay in their baseline PPE. What we definitely want to happen is everybody be on the same page. We need to do away with the on-scene debates that cause the medical control over disagreements on PPE. So if the on-scene clinician determines that baseline's appropriate, we need everybody to be comfortable with that, for that to be the decision to move forward on that call 100%. So that's kind of the 30,000 foot view. I'll let Richard chime in now, and then we can hit any questions that I might have missed in that.
So I think the one thing that's important to point out that this is a whole system event here. So the fire and EMS and Sunstar have to work together and making the right choices for the PPE for everybody. If one person on the scene says that we need to be in full PPE because they may have heard something, then we all need to wear the PPE properly as prescribed in the protocol. So the vehicle operator for Sunstar is not going to partake in patient care if it's a COVID patient. That way we keep the clean cab concept going. The fire rescue personnel is going to have to ride in, so we have two people to care for the patient and operate the stretcher safely and appropriately when we get to the hospital, and we're loading also at the facility or at the residence that we're at. So together with the company officers from the fire rescue departments and the EMS supervisor acting as safety officers, we really need to work together and make sure that we have the right level of protection on every single call. The word downgrade of PPE really needs to come out of our language for a while. It's baseline PPE, and then we upgrade from the doorway assessment, working together to do the right thing for the patients. So I think that's really where our stance comes from, and why Chief Womack addressed it in this sequencing of events at the calls. And together we can overcome this, and it really should be pulling the rope in the same direction and not having these disagreements. I do not have the questions up, Jasmine or Ian.
So I can see the chat. One of the questions is confusion about understanding if it was a RIP note, they're suiting up prior to the standoff 6-foot assessment. Again, we can't be overly prescriptive on that, because that's just going to depend on the area you're going into and the place you're going into. Understand getting dressed in your full PPE before your assessment or after your assessment requires the same amount of time. If you can safely implement a standoff assessment prior to donning the full PPE to confirm the need for it, then that is an appropriate thing to do. The overall objective here is to keep yourself safe. So priority 1, keep yourself safe. Priority 2, don't use PPE if it's not necessary to use it, because part of keeping everybody safe is making sure that our supply of PPE lasts for as long as possible. And key to that is not overutilizing it when it's not necessary.
I'm having to reboot to see if I can get to the questions, also to see if you want to keep going on it or if you need to turf one to me.
And let me scroll back up here.
Jasmine, can you help us with that?
Yeah,
Mine's
so
not coming up.
so I'll jump in and just reiterate something that you guys have both said. We are not downgrading PPE at any point. I mean, there's a lot of questions about downgrading PPE. And I think that some of the confusion comes from they just get on scene and they want to go backwards and take something off. But once you have it on, you keep it on. That's
Right.
really,
Yeah, that's a nice way to summarize it. And what we're just saying is be methodical about your decision to put it on. So, you know, the RIP note that shows up in your dispatch note is an early warning. It doesn't mean 100% of the time you need to come off and immediately gown up, because it may not be an appropriate time to put that on. You can do a standoff assessment and make that determination before.
Right.
to look at your call notes and think about the location you're going to. If you get outside and you realize in order to do that 6-foot standoff, you have to enter the location and you're questioning, anytime you're in doubt, put your PPE on. So you don't want to get upstairs in a house or, you know, be somewhere and then find out you need to put it on. You shouldn't be putting it on in their living room. So just look at your notes ahead of time and think it out.
Chief Bessler from Eastlake also wants us to make sure that we talk about bystanders, making sure we have bystanders 6 foot apart, but also when we're coming up to people outside, that we're maintaining the crew safety and mentality of the 6 foot. Somebody's asking about, does the full PPE change if dispatch notifies crews of the ISO precaution? Again, Chief Womack said that it goes back to your initial assessment of what you're finding, so your standoff assessment. Lieutenant Mitchell from Pinellas Park, to clarify, we're not downgrading RIP warnings. Lieutenant Mitchell, RIP warning in the notes of a call is for you to pay close attention to the call and still do your standoff. And then you're making your decision from your standoff assessment. That's just to heighten your awareness of this call, that somebody associated with it made a comment that hit one of the boxes for the RIP notification. That doesn't stop you or your crew doing the proper assessment. Okay.
Okay, so you guys fixed it, everything, right? We're all set? Everybody's clear? Couldn't be any more obvious?
There's mud.
Clear as mud. Perfect.
Don't downgrade PPE.
Yeah, we got to get away from that. And I probably hold some responsibility on the nomenclature for downgrade coming into play, because that's how we were describing it to our people. There's not a downgrade of PPE. I think the way that Richard just explained it was excellent. There's a baseline PPE and then an option to upgrade from there if you determine it's appropriate. But once you're in the full gown, nothing is saved by doffing it until the call is done. So we start all calls with baseline PPE, and then if in our standoff assessment we determine that we need a greater level, we upgrade to a higher level of PPE for the duration of the call.
I'd like to address a question from Michael Lowry. Is there a working list of facilities that have multiple COVID patients? So the answer to that is the Department of Health is handling all screenings or keeping track of locations that have multiple patients, not fire and EMS and not Sunstar. So this is a public health issue. And I know Dr. Jameson spends a lot of time with Dr. Choi to make sure that the responders are safe, and they give us the information that they're allowed to, but they're not sharing quite a bit. So we're not aware of any other locations at this point.
Okay, it looks like we still have some questions that things are not clear. So maybe we should take it from the top again on the PPE. It seems like particularly the concern is related to the RIP note.
So Chief Womack did an excellent overview of Doctor, what we've been talking about. And so from a different perspective, let's think of it this way. We're going to a 911 call or an interfacility call. Every single patient has baseline PPE, which is a mask, goggles, and gloves. From your doorway assessment, you're making a determination if you're going to wear a bonnet, a apron, and booties. If you put it on, it stays on. It doesn't come off until the patient is transferred. But that 6 assessment or that doorway assessment is where you're making a decision as a paramedic of what your next steps are going to be for treatment and how you're going to protect yourself and crew and everybody else. Everybody needs to be in agreement. If there is one checkbox of a symptom, then everybody wears the full PPE. So they upgrade to the gown, to the booties, and to the bonnet. But that's basically how we're working forward with this. The RIP note with the pandemic card that came out this past week, there's a little hiccup with that was fixed yesterday. And RIP note is just to get your awareness level heightened when you're approaching this patient or this residence or this nursing home. If you know you're going to a nursing home that's got several, put the PPE on. We're not telling you not to. It's okay to upgrade by what your local knowledge of your district is. So I think it works that way. Autumn, I hope that clarified better. And it is a little bit different than what we've been talking about. And that's why we wanted to lead off today with this PPE discussion, because we did have quite a bit of discussion on how to present this information.
Yeah, so it seems to me like the crux. Geez, 1 second. Sorry. So it seems to me like the crux of the discussion is, are you supposed to be in the full PPE when responding to a call that has a RIP note at the time you perform your 6-foot assessment? Is that the crux of the question? Is that Jasmine comment
Okay.
Is that what's being asked?
So the confusion is that Chief Bessler just said it in what we just released. It says if there's a RIP note, then one person needs to be in full PPE when they do the assessment. And what we're talking about now is that if you can do a 6-foot standoff assessment without going into a building or upstairs, that the first person can be in baseline PPE and then make a decision at that point. So there is some inconsistencies in that information. So I think that's where the confusion is.
Yes. Okay. So that's my understanding of where the point of confusion is. And it sounds like from the comments that that's everybody else's understanding of the point of confusion. So let's talk this through for a second. So there's two options. One is that as you get off your truck, before you get to 6 feet from the patient, that you're in full PPE based upon a RIP note. The other option is that you have your PPE with you and you're in the baseline PPE and make your assessment before you put it on. And so I think our original guidance was that if there was a RIP note, we wanted you to go ahead and have that PPE on, even as you approach to make your standoff assessment, at least for the one person. And then a second person could have their PPE ready and be a little bit further back. My understanding is that was what we initially put out. Is that correct? Can everybody let me know in the comments if that's how you understood the original guidance? Mitchell, Tedesco, Bessler? Okay, so that I think is good because that is what we initially put out and that was what we were aiming for. I think that there was some confusion among folks as to whether or not they had to be in the full PPE at the point of the standoff assessment. So the reason we're getting together today was to try to get us all on the same page because different people had been given different guidance. Some people have been given guidance to have their full PPE on at the time of the standoff, and others had been given guidance to have it available, but not necessarily on, just in the baseline at the time of standoff. So the unified command structure has discussed this at length. And what we're trying to communicate to you today is that if you are maintaining a baseline PPE, okay, meaning respiratory protection and eye protection, and you are having at least your 6-foot standoff, then it is acceptable to have your PPE ready, but not on. The gown, the rest of it. And the reason for that is because we want to make sure that we stay sustainable with our supply of gowns and everything else. The supply of gowns is becoming one of our pinch points. We're working on it, but we do have to be a little bit judicious about how we use our gowns. So if you're more than 6 feet away and you have respiratory and iPro on, you should be okay. If you're having to go deep into a facility, if you're having some other scenario where you're not convinced that you can be safely doing that, then by all means, put on the full thing and keep yourself safe. But if you believe that you can safely do that 6 foot standoff and you have your PPE ready there, if we decide based on our assessment of the patient that maybe we don't suspect it, then you could hold that gown for use on a different patient because we just don't have that many of them. Now, this is not to say that we don't trust dispatch. Of course, dispatch is doing the best job to get us the information, but people say different things. And the point I've made is the person who called dispatch, other than the patient, could tell one story and the patient could tell a different story. And you, doing your assessment at the patient's side, need to use an abundance of caution and protect yourself. So if there's any concern whatsoever, based upon a RIP note, based upon what you get during your standoff assessment, please use full PPE. But the difference we're saying now, and just to be clear, that was the original guidance that that first person doing the standoff was in full PPE. We're wanting to change this a little bit because there was differences of what people were doing. And after discussion, the guidance we're giving is that you may do the 6 foot standoff in the baseline PPE and upgrade from there. Have I stated this correctly, Chief Womack?
I believe so. I believe that adds an extra layer of clarity.
Mr. Schomp, have I stated that correctly to your understanding?
Yes, I believe so.
Okay, so now with that, because you guys should know, we're trying to get to the one best answer for you, and we know that people were doing a couple of different things, and we're trying to keep you all safe. The RIP is an awareness like anything else. The RIP is a heads up to you, just like any other scene safety or anything else. But we won't rely only on it. If you only maintain situational awareness and exercise scene safety when there was a scene safety speed note, you'd probably be in trouble. So we need you guys to take responsibility for your own safety as well. Dispatch is doing their level best to help us out, but we know that their information is only as good as the person on the other end of the telephone. So I don't believe we should take the RIP note out, just like I don't believe we should take a scene safety note out, even though you still should be maintaining situational awareness at all times and monitoring your scene safety. I think every advantage we can give our clinicians to be safe is a good thing, but this is where we are. Our supply of gowns is a bit low. We're working on it, but right now, this seems like the most common sense approach that the unified command structure has agreed upon. So let's see if we can get everybody on the same page here. Any other questions about this one? Okay, so here's a couple. Can we clarify use of full PPE now for abdominal pain, nausea, or vomiting? Okay, yes, we can. So dispatchers, I've instructed them to ask about diarrhea specifically when it comes to symptoms, because we are learning that some percentage of people have GI upset or diarrhea as a presenting symptom somewhere in the neighborhood of 5 to 10% of cases of COVID. That's why we've added that in. It's not a normal question in the respiratory stuff. We've added it in to try and keep you safe, which means if you're asking those questions and you get a positive answer, you really should take full PPE. Hopefully that answers your question, Brantley. Pinellas Medic, can we have dispatch write into the notes what flags the call for RIP? Sometimes all it shows is RIP and no information on what flags it. We can try to do that. I know it happens sometimes depending on how the call got processed, but not other times. What I would say is I would hope that you would ask all the questions when you're doing your standoff, regardless of which one flagged it for the dispatcher, because we have this experience all the time in the hospital. The medical student goes in and asks a bunch of questions and gets one set of answers. Then the intern goes in and asks the same questions and gets another set of answers. Then the resident goes in and the same thing happens. And by the time I go in, we've got 4 sets of different answers to the same question. So what I would hope is that you would take the responsibility to make sure that you're asking all the questions, regardless of the RIP note, to make sure that you keep you and your crew safe. But I will look at if we can make those details show. Let me just write that down real quick. Okay. What other questions can we answer about PPE? I realize this is a little bit confusing and we're trying to clarify and get everybody on the same page because there was clearly some different interpretations of what we were doing. And our situation has changed a little bit in terms of our PPE call volume, et cetera. Okay, Michelle, can dispatch. Oh, that's a wonderful question from Michelle M. Bryan. Hey, you guys, chime in the comments if this is something that you're seeing as well. If a couple people saying they're seeing this significantly, we will move quickly on it. But I will put that on my list as well to look at that verbiage as to the post-dispatch instructions they're giving. And while we're waiting for that, Chris says, does this change any of the PPE requirements for aerosol treatments and cardiac arrest? No, it doesn't. And the reason we have the full PPE gown and everything for those procedures, which is cardiac arrest, aerosol, airway management, anything like that, the reason for that is that even if you do not suspect COVID in those patients, those are aerosol generating procedures, and something in the neighborhood of 20 or 30% of people infected with COVID can be asymptomatic. So if we say that 20% of our respiratory folks where we're doing an airway management may have unknown or just totally occult infection, then it makes sense to protect ourselves on those calls. Okay, so we're seeing it with family and friends, hit or miss. Okay. So I will go back to the post-dispatch instruction notes that the dispatchers are giving and see if we can make those get you guys a better result with how the patients are approaching you or waiting at the front door. That's a great bit of feedback. Thank you. All right. Were there any other questions from earlier before that we didn't get to, you guys, or Jasmine, did we get through most of the stuff?
I think most of the questions were related to PPE.
Okay.
And the questions about the pandemic card. I haven't seen any, but I've received a lot.
Okay, sure. So I'll just answer Autumn's here real quick. This will be very difficult to see a seizing infant with a febrile seizure from a 6-foot standoff and leave them to go get dressed. Yes, agreed. And so based upon your pre-arrivals, you know, hopefully you have your PPE with you, and in that situation, maybe you want to just put it on. You know, these are difficult times. You know, I had a patient come in yesterday in severe respiratory distress, and I had to take, you know, a couple of seconds to get dressed outside the room before I went in because, you know, we're doing aerosol generating stuff, and we have to protect ourselves. The infection rate among healthcare workers and EMS is clearly higher than the public. And so we really are on the front line of this thing, and we have to take appropriate PPE.
Matthew DeMarco has repeated his question. We did miss that one earlier.
Oh, great. Okay, so the COVID category red CPR protocol states to only initiate resuscitation if initial rhythm is VFib or bystander CPR. Is this the same for pulseless VTAC as well? Good question. Yeah, we should probably clarify that. That makes a lot of sense. I know some other places that were getting really hit hard were even talking about throwing an AED on, and if it said shockable rhythm, then they would go, and if not, and certainly that's a shockable and relatively high survivable rhythm. So let me write that down. By the way, I am still hoping we never get to red or black, but that's a great catch. Thank you, Matthew. Doug, about the facilities, I think that got talked about a little bit before, but we are working on trying to get better coordination there. Yeah, Jeff, I hear you. And Autumn, I hear you. Peggy, I hear you. It's not easy. And so this is where we're asking you guys to use your brains. But, you know, it's probably the same thing as running into a burning building without putting your air pack on, or whatever other risk you decide to take. You know, there's tough decisions that have to be made, but I really want to emphasize that my goal is to get us through this without losing any of our responders. And I wish the same could be said for all the EMS systems around the country. But unfortunately, there are multiple first responders who have died from this already, not just in New York, but you know, other places as well. So I just can't emphasize enough how important it is to keep yourself safe. What else we got? Dusty says we had a facility who brought a patient out to us before we were ready. They took your temperature even though you didn't go in. Perfect. Thank God. Safety first. So wonderful. So yeah, Dusty, I will work on the wording of those instructions to see if we can make that better. And to that, Mark says, is there any progress on facilities accepting our daily screening? So that is one of the things in the instructions as well about telling that staff that you guys have been screened. So hopefully that'll get better. But okay, Nathan says, right now in condition yellow, if we have a patient with COPD exacerbation and signs and symptoms of COVID, can we still initiate the aerosol treatment, but just withhold the Solumedrol? So the answer to that, Nathan, is you could. It is not 100% prohibited like it would be, say, in red or black. But the preference would be that you try to use an MDI, or if there's no MDI available, you know, like the patient's own inhaler, that you go to epinephrine instead. So I would say that from a risk-benefit strategy, what we're hearing from the hospital is that the patients in this situation generally are doing pretty well using supplemental oxygen without the nebs, even with their so I had a COPD patient last night that was sort of on the border there, and we managed to nurse him through with oxygen instead of doing aerosol generating, which would have been particularly dangerous to the staff. So it's not an outright prohibition, but it's certainly not a best practice, and I would try very hard to avoid it. If you decided to do it, meaning give them that neb, I really think you need to consider not doing it in the back of the ambulance, minimizing the number of people who are around while you're doing it. Maybe do it outside before you load in the ambulance if you can. But once you get into that level of complexity, I'd rather have you just move to the other options and keep moving forward towards the hospital. I know that's not maybe 100% satisfying answer to your question, Nathan, but some of these things don't have great answers at this point. You know, if we all were in spacesuits and had negative pressure ambulances and all that, it might be a different story, but that's not the world we live in. Okay. Chief Bessler, concern for patient care when wearing the 3M P100 mask, difficulty communicating. Yes, we know that's an issue. And so I don't know if Chief Tedesco is still on and wants to chime in about any experience they've had moving towards SCBA masks with voice amplifiers on them. But it is certainly an issue related to risk benefit. The P100 and N95 should both be adequate protection. The one nice benefit of the P100 is that you get your full protection over your eyes as well, but it does make communication difficult and it's a little bit cumbersome for some people. So that is definitely a concern. I've done a couple consults where it sounded like you were talking through 3 inches of plexiglass, but we managed to make it work. So hopefully we'll have alternatives there, Chief Bessler, but it is absolutely about sustainability. We do not know how long this thing is going to last, and we do not want to run out of N95 masks. And we can use a full face respirator with a P100 cartridge for a heck of a lot more patients than we can use an N95 mask for. Mitchell says, are we using the mass casualty bus for facilities that have COVID breakouts? Yeah. So okay, so before we get to that, Tedesco did chime in. All of CFR is using their SCBA with the new adapters. Any other department can do this too if they have the assemblies. So for those who don't know, there's a adapter that got made to take your SCBA mask and attach an appropriate P100 filter to it. And that allows you to have your voice amplification and all the other stuff of your regular fitted mask. So anybody who's interested in exploring what that would look like or how they might do that can certainly reach out to Chief Tedesco, and I'm sure he'd be willing to share that process with you and how they validated that and made sure it was okay.
I have some questions that have been texted about the process when evacuating facilities and notification of different units.
Okay, so I guess we can talk about that, the one facility where we've taken multiple patients out of. So what I'll say is that we became aware that there was a few patients at a facility and started coordinating with them and with Department of Health and with the receiving hospitals. And we tried to make as smooth a process as possible. However, we ran into a little bit of logistical hurdles. I think it's worth noting that the fire district that was involved was notified and involved in those discussions prior to any patients being moved. And I think it's also worth notifying that, or worth saying, this was not an evacuation of a facility. It was a movement of a number of patients. And we continue to work with Department of Health, hospital partners, facilities, and Sunstar and the fire agencies in those districts to make sure that if we have to do a similar thing in the future, that it goes as smoothly as possible. We have seen across the country that older folks are disproportionately affected by this virus. And we have seen some really tragic events happen in other places. And a lot of people are trying to make sure that we don't see similar events happen here. And so that was an initial first time. And if something like that happens again, I hope that we get better at it. But there is no facility evacuation or anything like that going on. And no plans to do any further ones of those. We will do our absolute best to continue to keep everybody updated on any location that we start to become concerned about or maybe a better way to say that is that the Department of Health starts to become concerned about. And we will continue to work with everybody who's got responsibility and a hand in trying to keep our community safe. So I know that that one, had some things that we all learned from, but hopefully we'll get better at it. Here's an interesting one.
Dr. J, I'd like to chime in for a second on that.
Sure.
With Lieutenant Mitchell's question about using the multi-casualty bus for that. So what we found with moving just 10 patients, the hospitals really can only receive 1 or 2 at a time of a COVID style patient, and it has to be a planned event. If it was treated like a normal 911 call where we go in and we just clean it up and get it taken care of rapidly, they wouldn't be able to handle it on the receiving end, and we would have a log jam there and overwhelm their staff. So by moving a couple every 15 to 30 minutes in a staggered fashion is the best way to do it. Also with the environment of keeping people wrapped in the yellow blankets and in their own environment for care probably works best.
Good points. And I think this is maybe sort of a corollary to that, actually. It was Ben's question about dropping a patient off and having to wait outside a little bit for the hospital to be ready. The same thing would happen if we showed up with a bunch of patients all at once. So to that point, one of the things that we asked is for you to give the hospital as early a notification as you can, and to make sure they're ready to receive you before you start approaching in. So if you have to stay in the truck a little bit, I guess that's probably okay. Hopefully you've called ahead and have coordination. But certainly it's going to be hot if you stand out in the heat in your PPE for a period of time. So certainly something to think about there. And let's see, there's a couple others here.
Adam Stacy on the bottom, that's a good one.
Interesting question. Yeah. Adam, so this is a discussion between the epidemiologists from Department of Health and the facility staff as to what's going on in the facilities. Our role in this is to help support them when they feel like there's patients that need to be moved. And so I'm under the impression that they tested a large number or a large percentage of that facility. But I do not know if they tested everybody, and I do not know if they took all positive people out, just as I don't know if all of the test results are back yet. So there are people at the local level, at the state level, and at the federal level who are trying hard to figure out how to best mitigate these situations. And talking to some of my colleagues in New York, these things in some places have been very, very difficult to control. We all saw what happened in Washington when this first started with that nursing home out there. I think it was in Evergreen, right? And we're trying hard to figure out the best way through all this stuff, but this is a novel virus, and we're like I said, we're trying to do the best we can. But again, this is a healthcare facility that's working closely with the Department of Health, and our role is to really support them when they say that they need patients moved in a safe and effective way. And Mitchell says the outbreak of COVID in a local facility has been synonymous as a tipping point in other symptoms. So we don't have a good answer on how that ties to what is going on in the greater community. I think we all know that older folks are at particular risk, and communal living situations are at particular risk, i.e. the cruise ships and other facilities. No, I don't think we know exactly how that correlates with what's going on in the community. And I'm not sure that I would call this one a significant event for our system, if that's what you're meaning, Ryan. I mean, we move hundreds and hundreds and hundreds of people a day. I think it's probably a significant event for the facility or the result of a significant event in the facility. But for us, I think we handled it pretty well, actually. And are we implementing, trialing the refusal at home protocol with this facility? Nope. We have physicians and nurses at that facility who are working with the DOH staff and making decisions about what's right for individual patients. Were these patients already counted in Pinellas number, or did we see a big rise in today's numbers? Again, I'm not sure what the status, whether they've already been tested, tests are processing, tests are being collected. So I couldn't tell you what day particular numbers would go in. I can tell you that we had a bit of a jump in our hospitalization numbers in the county, and that makes sense because we took a handful of people to the hospital. So I know that one, made the news and everything, but there was no big secret there. Let's see what else we got. Looks like Chief Magnus and Jackie, hopefully they got that thing squared away. And look, I'm talking very closely with the DOH and doing my absolute best to make sure that we stay informed as to where things might be popping up, and so that we can stay ahead of it, and so that we can keep everybody safe. But these things move quickly. The virus is very contagious, and so we had, for example, we had it's acting very strangely. We've had a couple of cases in the hospital now where people initially tested negative and then subsequently tested positive. So we've also had some cases where people tested negative, but then it seems like maybe they really did have it. So there's some stuff we're still learning about this virus, and it is acting a little bit strangely. So once again, it comes back to protect yourself. Don't take anything for granted, and make sure you're using appropriate PPE on every call. This is the only facility dealing with this sort of outbreak that I'm aware of. I think it's not a surprise, and it would be a true statement to say that there are cases in other facilities, just as though there are cases in hospitals. But I do not know of any other facilities that are facing a similar situation. Bill says, what are your thoughts on what some experts are saying about herd immunity? They're saying if we keep flattening the curve, we're just pushing the peak further away. Yeah, but I'd like to say push the peak further away, because that gives us more and more time to have appropriate resources in place, gives us maybe most of all, more time to learn more about this particular virus, which again, is sort of becoming notorious for acting in strange ways and being difficult to deal with. So herd immunity is a true thing, but herd immunity only takes effect when you have something like 80 or maybe even 90% of the population who's had it and recovered. So I do not believe this is the virus that we want to have chickenpox parties with. I think we do much better to frankly drag this thing out and slowly get back to normal, rather than just say, oh, well, let's all just do it. Because if we do that, we're gonna have a lot more sick people. And there are young, healthy people who are dying from this thing. It's being a strange bug. Essler says, I've seen significant backlogs of ambulance patients processed. Yeah. So the alternative, Chief, is us having to go into the facility, which creates all sorts of other issues. It burns, in many cases, 2 or 3 times as much PPE per call. and it complicates our processes a lot. And so having seen this happen different ways at hospitals in other counties, I still think that this is the best plan to do that ramp or entryway handoff. If there's a particular hospital that's struggling with the logistics of that, maybe offline, you can let me know and we'll reach out and share some best practices. Yes, Chief Bessler, hopefully I just answered that question. Yeah, it could be an improper test, but it could also be that the viral shedding seems to have some periodicity to it. I don't know, that's not a word, but it seems to come and go in patients a little bit. And, this is not unique to like a particular tester or a particular laboratory or something. This is being seen in lots of places. So thank you, Chief. Glenn says, any timeline from about antibody testing? So we have ordered antibody testing that would cover every single first responder in Pinellas County up to 4 times. We're working through those protocols. Some agencies have procured tests via different mechanisms. Our big order of tests is probably still a couple weeks out, but we are working through protocols to try to get every single fire, ambulance, and law enforcement responder in the county the ability to be tested multiple times for the antibody testing. Mitchell, going to the facility, curious about treat on site versus transport. Yeah, so those discussions are ongoing. The decision by a bunch of people involved was made to offload some patients from that facility based on a number of considerations, I believe. And so that's what we did at their request. Field hospitals, et cetera. I think lots of different things are being discussed right now, but I don't know that there's a definitive plan like that at this point. Jim says, are you aware of any issues with patients that are being affected by the healthcare system's focus on COVID? Yeah, that's a really great question, particularly with all the cancellations of elective procedures. And I did actually reach out to the medical examiner the other day going, hey, just out of curiosity, since we're seeing such a low volume of calls, like, are there a bunch of people who are just like dying in their houses and we don't know about it? And so far, based on what he was able to tell me, is that we're actually not seeing some big uptick in unattended deaths or complications from things like missing dialysis. But it is an interesting question, and a question that's being asked by medical directors across the country. Actually, I was on an Eagles call the other day, and everybody's like, "So, where are the cardiac arrests?" And we don't really know. Excuse me for a minute.
Feel free to keep firing off your questions.
Yeah, sorry about that. Okay. Jasmine, did you have other questions that were texted to you? Or did we cover it?
Most of the questions that I had were on the pandemic card. So in the situation that they're dispatched to a pandemic call, should it be the same standoff and wear your baseline PPE until you get there?
Okay, sorry about that. So it is a blood test, Dusty. It's a finger stick like a glucose. And does the ME do COVID sampling on deceased? Yes. They do in some cases. Okay, cool.
I was going back to that pandemic card question. I think that question came from somebody who's not in this group right now. But
so then it's probably worth just explaining what the pandemic card is and how it works again. Make sure that everybody's on the same page. The pandemic card 36, is a card that basically takes a couple of other routine kinds of calls that or natures that would often be associated with a possible COVID case and funnels them through a protocol specific to try and tease out whether it's a potential COVID case or not. And the bottom line is that if they have RIP-like symptoms or COVID-like symptoms, it will kick it out as a pandemic call. There should also be a RIP note there. There was an issue going on that I believe has been fixed, so that as of yesterday. So that disconnect between the COVID or the pandemic determinant and the RIP note should be fixed, hopefully. But once you go through this, if it doesn't find any of those type of symptoms, then it will actually kick you back out to the regular call type that would have fed into it to begin with. So in this particular case, so example, one of the call types that goes in is the 26 card or sick person, and it will go through and try and figure out based upon the questioning if that sick person call is a potential COVID call, and then if it is based on the questioning, then it'll come through as a pandemic with a RIP note. If it's not, it'll shunt back to the 26 card. So hopefully that kind of clarifies what that card is about. And there's a couple of determinants that go into it for that additional questioning. All right, so any stats or trends or studies on whether we expect to see an increase in suicides based on quarantine? That's a really, really interesting question. Overdose, domestic violence, suicide, all those things. We do have some suspicion that we're going to see an uptick in that, and some preliminary data that Dispatch put together that we may actually have seen a little spike already in those compared to a similar time last year. It's not a big percentage. It was only like a 1 or 2% difference right now, but it is something that we are looking at and something we do certainly anticipate. There are some additional mental health resources that are being mobilized to support people through this, and as well to support us through this. Certainly the 911 Center has done some good stuff with that, and there's a few other resources that are coming online as well that we'll share with you as soon as we have the details on them. But yeah, that is certainly a concern. This is stressful for everybody, without a doubt. All right, so it's 5 o'clock, and we've had a bunch of questions, so there's a lot going on. One thing I will say, just going back to what Ryan asked before about if the facilities are, if seeing more cases in facilities could be an indicator of what's happening in the community, I do have some concern about that. Yeah, I do have a concern that if we start to see a significant increase in cases in facilities, that could be the harbinger of a significant increase of cases in the community. So I am a little concerned. I know you're seeing stuff in the news about, oh, it's flattened out, we may be getting close to the hump. The projections still have us with a couple of weeks before we get to our worst days. And I'm still not comfortable or confident saying we're on the backside of this thing by any means. And I do have some concern that we could still see a significant spike. Dusty says, with the pandemic patient in the EPCR and the dispatch tab has been dropping the call reason, not a huge deal, just FYI. Dusty, can you send me an email with the details on that so I can pass it along? Because I'm not sure I understand exactly what you're saying. And I'll get it over to the EPCR people. All right, with that, I think we'll ask for any final questions and throw it around to Mr. Champ. Anything else you'd like to mention?
Now, I just want to say thanks a lot for the questions today and the dialogue on the PPE. Good conversation about the movement of patients out of the nursing home in Seminole, also to get all the information out to everybody. It's important. Also know that we've worked on a really good plan on how to move forward for if we have another one of these types of events and how the process will flow. So good stuff. Appreciate it. Have a good day.
Chief Womack.
No, just thank you to everybody working together. Ambulance and fire doing a great job working together. It's encouraging to see the types of questions we're getting, because that obviously is an indication that the field is working hard to implement and follow the guidance that they're given. So that's reassuring. And we're confident that what we're putting together will keep you guys safe. So we appreciate the doc's diligence on that as well. Thanks. Thanks for doing the calls.
Jasmine?
That's it. Thanks everybody for being here. If you have any questions that you need to have asked in these that you don't want to type in, feel free to email me or text me, and we'll continue this next Tuesday.
Great. Yeah, I can't echo that enough. This is a difficult time, more than others, to do the job that we're all doing together here. And I understand that there are frustrations accompanying that, just as I have frustrations on my shifts in the hospital when things, are difficult and logistically tough. But I think everybody overall is doing just an amazing job, taking really good care of our community and each other and themselves. And that's what I'm most hopeful, that we all get through this safe and sound. So please be careful out there, continue doing the good work. And if there's anything that you can think of that you didn't get a chance to mention today, please jump on Thursday and let us know, or pop an email, because we want all the ideas about how to do this the best. So thanks very much. And I think with that, we'll go ahead and sign off.
Thanks everybody. Stay safe.